Great. Hello, everyone. Good morning. Thank you for joining us today for an MVC Health Equity Work Group. Christy Degner and I are the site engagement coordinators for the MVC Coordinating Center, and we look forward to facilitating today's work group. Today's Health Equity Work Group is featuring a presentation by Janée Tyus, a Senior Program Director for the Greater Flint Health Coalition's Mid-Michigan Community Health Access Program, known as CHAP. Janée holds a Bachelor of Science degree from the University of Michigan, Ann Arbor, and a Master of Public Health from Drexel University's School of Public Health. Janée serves as the Senior Program Director for the Mid-Michigan CHAP program of the Greater Flint Health Coalition, and as an adjunct lecturer at the University of Michigan-Flint. She recently served as the co-chair for the MDHHS Community Information Exchange Taskforce from 22 to 23. So thank you, Janée, for joining us today for the work group. Just before you begin your presentation, I'm going to go over some brief housekeeping items. I have tongue twisters today. Today's work group will be recorded, is actively being recorded in the slides, and the recording will be shared with attendees following the work group. So you are welcome to follow up with any questions you have, or if you know anyone who's interested in reviewing it, you can share that as well. We'll be monitoring the chat throughout the presentation, so you can add questions there or you can save them for the end. And then, of course, we have a post work group survey, and we really do appreciate your feedback. It is important for us to tailor our future work group offering. So if you could complete that, it'll just take a few minutes. And with that, I'm going to stop sharing and you can pull up your presentation, Janée. Thank you again.
Thank you for the introduction. Just a quick thumbs up that you guys, nope, it's not the screen I want to share. Give me 1 second here. I want to show you this one. Can you see my screen?
Looks great.
All right, wonderful. Thank you for the invitation and the introduction and for managing all of the letters that makes this a mouthful. So again, I am the Senior Program Director of the Mid-Michigan CHAP. I love it because to me, everything is in our name. So I look forward to speaking to you guys about our program, how we operate, and just how it aligns with health equity in general. So one of the main things I just like to start with is the fact that this program was created because of the fact that we know in our community that what happens and makes people healthy doesn't occur in a clinical setting. It's the stuff that's around them where people live, work, and play that often causes individuals to not achieve the best or the optimal health outcomes. So about 8 years ago, CHAP was created to address the issues that we were seeing in Flint and Genesee County and still do today. Specifically for children, we were seeing them not going into the doctor for their well child visits or immunizations early on. We had a lot of children with chronic conditions such as asthma. Folks were going to the ED for the wrong reasons, like for earaches, when instead they should be, going to their primary care provider. So CHAP was created to really address the disparities that we see and the activities that we see occurring as it relates to healthcare for our population. And if I could talk a little bit about our purpose, and then I'll share a little bit about our coverage areas. We were created to be community-based, to always be a community health access program, one that focuses on the community, the whole person and people, and helping them achieve those health outcomes through making connections to resources and teaching people how to fish and navigate things in their life that sometimes come before they can even think about healthcare. So we've been able to, as a program, help improve the utilization of resources in our area. And we've also sort of achieved some cost savings because of how we operate. And these days, I really think of us operating in sort of a social care coordination way. Like we provide social care coordination to people referred to us, and we take a population health management approach to that. So we are mindful of the populations that we're serving, the needs in which we're serving them for, and then the outcomes of those needs, and kind of looking at it and seeing if we're achieving or improving the health equity in our community. This slide's a lot, but if you could remember anything about what we do and what areas we focus on, this at a high level is that we always make sure there is a strong connection to the medical home. This also includes a dental home and other specialty providers. We are sort of the individuals or the program that stands in the gap when people are about to be kicked out of their PCP office and they're like given a last chance effort. When we're trying to make sure folks have that strong connection to the doctor, we end up uncovering the second bucket, which is the social determinants. That's the stuff that prevents people from even thinking about using healthcare appropriately because this stuff is on their mind. Transportation, housing, and food are typically the top 3 things that we have to help people navigate. Emergency department utilization is key because that's where you get high cost, low value care. And we've been able to reduce that based on our engagement in our education strategies. HEDIS is new. That's the healthcare effectiveness data information set. I believe I said that correctly, where we're trying to just get people into the doctor for the stuff that's preventable to help them manage things that they've got going on. So kids getting to the doctor for immunizations and lead screening, adults getting screened for, let's say, their A1C or chlamydia screening even. We're addressing that stuff by providing education and support to get to the doctor in that way. COVID hasn't gone away, so we're still in this space where we're distributing COVID masks if they ask for them, or maybe even these isolation and quarantine kits. And addressing vaccine hesitancy is really key because it started with COVID and then permeated to the left as it relates to a lot of people in our area don't want to get vaccinated anymore. So we do a lot of education as it relates to that. The logo that you'll see on the screen and on my scrub jacket today, because I'm headed to a practice after I talk to you guys, is this is how we work. We don't achieve anything by working alone. So we work together with the clients, their providers, and we work at the systems level. One of the things that we were able to achieve through this partnership and how we operate is that in Genesee County, there is no longer a 72-hour notice rule required to book Medicaid health plan transportation. We got it reduced to 24 because our clients were struggling, our providers were struggling, and the system needed to change. So that's a good example of how we've been able to work at those 3 levels and advocate for stuff that makes life a little bit easier for our community. This is sort of how it works at a high level. I'm just scratching the surface of CHAP today, but I wanted you guys to see that the workflow is truly, individuals are screened for social determinants of health in an external location, usually a clinical setting, or even a community-based setting. These days, we've expanded our work sort of a ton, and I'll show you how much we've expanded later. But that screener and one's individual saying, yes, I want help with that, results in a referral to CHAP in whatever way works for our partners. And then we then engage and we connect, we get consent, and we really are the bridge between the clinical side and to the people and them to the community-based resources. So most of the stuff that's identified externally comes in the door and then it goes out the door, in connection to another resource. And we try to do this in a closed loop manner. So we let the provider know what we were able to do, and we like to engage directly with our community-based organizations as well, because we like to know that a person truly did get their need. It's not a referral that we don't follow up on, if that makes any sense. So we close the loop in this space of CHAP. I am very biased because they're my team, but they're fantastic. So the team is comprised of community health workers, we have nurses, and we also have social workers. And then we have sort of operational staff like myself that don't often engage with the clients, but help keep the bus running. And I try to make sure that team feels adequately trained and they have tools in their tool bag to handle the stuff that they experience. So our CHWs are trained according to the state standards. We encourage people to continue their education and maintain their licensure in good standing. So there's lots of tools that they use. And we also have child passenger safety techs on site because transportation and car seats is huge for our community. So we're able to install them and get babies being transported safely. I'm going to skip probably our lead mitigation and prevention programs. This is a specific population of focus where lead is an issue in Genesee County. So we do operate a couple lead mitigation and prevention programs. In our county, we are the operator of the elevated blood lead level nurse case management services. That's normally a health department thing, but not in GenCo. We do it. So that's a longer term case management where we're honed in on those individuals in the lead impacted population who need social care connection and coordination. We also operate a primary prevention program where we are screening for social determinants and lead risk at the OB. Those then get referred to CHAP. The nurses will engage and reach out and assist in mitigating the lead in the home before there's a mobile baby, so we don't see elevated blood lead level, trying to be a little bit more preventive. So CHAP does a lot of stuff. We also operate a lead-related program, which is a family supports coordination program, where a social worker will engage with the population that's been impacted by the water crisis and will really meet with them one-on-one and address and plan like a year's worth of how they can operate together to improve the children's cognitive ability, make sure they have a strong connection to a doctor and school, and go from there. I'd like to talk a little bit about our referral partner so you can see the scope of CHAP. This is outdated every time I do a presentation, but we now probably have relationships with, I think it's over 100 at this point, physician practices where we have established memorandums of understanding and business agreements, because we like to close the loop and make sure people know how we operate. We work very closely with our physician organizations of those independent practices and community-based organizations. And we're now getting into the space where of those physician practices, some of them are specialty clinics. Hospitals is going to be on this list in just a second, as it should be. And so we're really doing a couple of things as it relates to focusing in on a population, and then one day evaluating if our CHAP model that works in its current state can affect the same change for those additional populations. We also have relationships with our Medicaid health plans, where in our county and our coverage area, we have established community health worker agreements where we really focus on whatever they and us agree on in our scope of work. That relates to improving HEDIS now more recently because of the redetermination, making sure people actually maintain and retain their healthcare coverage. So I'm just trying to paint the picture of how many different places and spaces we are operating in this community. I usually want to talk about eligibility. It's anybody. This slide kind of is funny to me every time I talk about it, because people that have a need, they have a social determinant of health and want some support from CHAP will get it essentially. And we try to make sure things come in the door through a medical home or through a health plan to maintain how we operate in that three-way system where we're working with providers, clients, and at the systems level. So pretty much anybody at this point is able to be referred to us. And this coverage map that I shared earlier but didn't speak to is indicative of that eligibility. We are always going to be Genesee County based, but our coverage area has grown for a variety of different reasons. And I am excited about some of the stuff that we'll be able to see and replicate in those additional counties. I like to talk about how well they do their job, because I think it's important to share not only how we operate, but the success in which we're able to achieve because of it. So consistently we're resolving, meaning a person's need was actually met. One person got food, or one person got transportation scheduled and coordinated for their doctor's appointment. So that's what we mean by referral reason resolved. It's a good thing. Now, the other data points are still good because they indicate a few things for us. It's unfortunate that it's often difficult to get people to engage. They get the referral and then don't want to work with us, or we get them and they lose contact with us or don't want to engage anymore. Or the other one is that we just could not reach them. You know, it's sometimes the population that we serve, they change phone numbers and addresses. So it's difficult to actually maintain a strong connection when you have a transient population. I love talking about this slide because I care about not only how the staff feel and how they operate and the numbers, but we care about the patient, the person, and their experience with us. And this is just an indicator that our staff are teaching people how to fish and navigate their community and things around them. And they're doing so in a manner that is helpful to individuals. We send out a client satisfaction survey every month. At this point, we're serving probably over 2,400 individuals a month, and that's unique. And of that, about 12 to 27% of the people actually complete this survey. Most of the time they say good stuff. So this is very good to me to hear too. I like to just paint a couple pictures about some successes. So this is where I'm going in a second. Hurley Children's Center was one of our first pilot practices. We started with 5 and now we're over 100. And this family was with us for a long time, since 2017, for a bunch of stuff. And our staff have, really wrapped their arms around this mom who was experiencing domestic violence. They'd all been abused and she was pretty hopeless. So we've gotten, we moved some mountains for this family and they are in a better space. I think she is no longer at a shelter. She was now able to get some housing, and we are able to see this family and their children thrive a little bit. So this one isn't closed yet. We're going to keep working on it, but this is the type of stuff that sometimes it takes a long time to make a difference, but we will work with people until we can close that loop. Here's another one where this individual was referred to us just for a HEDIS gap that they needed to get to the doctor in their first trimester. Once our staff engaged, she identified that this mom didn't have access to water, needed housing, and she needed a car seat because baby was coming soon and she didn't have that. And this one's easy. So we typically have water filters at home. Here at home, where we can give them to our families and we just drop them off typically. She's got some car seat education. A car seat was installed, and then she's also connected to multiple housing resources and housed at this point. So this is good. What's this last one? This one's important to me because sometimes providers prescribe stuff and a family can't adhere to their treatment plan for one reason or the other. So this is an example of a young one, autistic baby boy who was going through ABA therapy and he was improving. Then he started to regress and the doctor realized that he was regressing. Our staff reached back out and it was because mom couldn't get him to the doctor. Couldn't get him to therapy anymore. So we had to coordinate transportation and we actually had to advocate for this client with our transportation provider as they were denying their ability to use that service because of some paperwork. So we were able to complete the paperwork and coordinate with our transportation provider and the family. And this little guy is in a better space, going in the positive way now. There's a bunch of stuff at GFHC that I normally like to talk through. We have a few programs as a neutral convener and kind of a backbone organization that operates community-based programs. My program is the largest of them, but we have things like substance use and abuse that we're educating people on. So we're responsive to the opioid crisis and educating folks about addiction. We have a Connecting Kids to Coverage program where we are not just trying to help people enroll in Medicaid, but help them retain that coverage. And I could keep going on and on about all of the resources that are within this organization. So it's kind of cool because when we get things in and we work them in CHAP, sometimes our referrals are to our partners in the same building. So I think that helps us be successful because, again, we're able to close that loop with them as well. I think that I have pretty much, this is sort of my team. I'm the senior program director. I've got an army that works under me. So Hannah's the one, if you want to learn more, I would reach out to in addition to me. Rachel is actually at a provider practice where I will be heading after this, and she can help with all of this good stuff. So I'm hopefully, I can't see anybody's faces. I'm going to stop sharing my screen. Are there any questions at all?
Thank you so much, Janée.
You're welcome.
I have
All of everything that you do is amazing. I just want to say that, but go ahead, Christy.
Thank you. I think they're amazing. Yeah, I've got the privilege of an amazing team under me.
Irene, did you have a question? I saw you unmute. I want to give you a chance first.
Thank you. I did. This sounds amazing and a wonderful resource. I am in the southwest portion of the state, so it doesn't look like we moved up quite this far. But I'm wondering if you know of any similar services like you're discussing that I might be able to contact here.
I cannot hear you clearly. Did either of you pick up on that?
I think, Irene, I think you were asking if there's any similar services in Southwest Michigan, correct? Because
Yeah.
yeah. Do you know of any like programs out there?
Okay, give me a county in Southwest Michigan.
Calhoun.
Calhoun County?
Yeah.
No, it's unfortunate that the model that I just shared today is not everywhere. There are a few other like regions that operate similarly, but very differently. So there'd be like the Livingston County and Washtenaw area is one. There's one in the UP, Northern Michigan. There's one in mid-Michigan, I call it, not my version of mid-Michigan, but the in Kent County and Grand Rapids. So I'm not familiar, Irene, with any CHAP related or similar CHAP in Calhoun County.
Okay, thank you.
Good question.
And then I had a question for you. Could you talk a little bit more about like the referral process? So once someone's identified, the next steps for that.
Yep. Let's see. I'm going to go through. Here is what happens. Typically at the provider practice space, the need is identified based off of a social determinants of health screen. The individual is then told that they're going to get a referral to CHAP because they have needs and they want some help. Then the provider practice would complete this referral form or something similar. Sometimes they just send the SDOH screen with the face sheet, but normally a referral comes in one of these ways that you can see here. Our practices are primarily faxing referrals to us. It's the best way for them. Then we have this Find Help portal that some practices are logging into a computer and sending us their information. So that referral process really depends on what the external entity prefers. I don't care how it gets here, as long as we have enough information to address it. And then once that thing gets in, it takes about 48 hours for the referral to get entered and assigned to an appropriate staff. We've got a bunch of logic, a bunch of teams, and a bunch of processes that help that role. And then we engage with the client and we make sure they know that we are partnering with their provider. So we engage primarily telephonically. They pick up the phone and try and make a first contact attempt. And based off their level of engagement with the person and the needs, they'll begin to work the process of maintaining that client and their referral and addressing those needs. Hopefully that answers your question, Christy.
Yeah, that was great. Thank you.
Go ahead, Erin.
I have a quick question. So, echoing, I think what a lot of folks on this call are feeling is this is tremendous work. The Greater Flint Health Coalition does amazing things for the community at large. And, recognizing that CHAP programs or resources and support like the Greater Flint Health Coalition provides aren't available across the state. I'm wondering if you could kind of talk through just the kind of convening and collaboration process that you've used. I think one of the things that folks typically feel is, if they're doing social determinants of health screening in a practice office, they might not know where to send folks. And I'm just kind of curious, are there lessons that you've learned just in terms of building relationships and connections that you could share with the group?
Man, collaboration and partnership is just critical. Because of what you're saying and wondering if this type of a program exists in your area is why CHAP has had to expand our reach and our coverage area and be a bit more malleable in how we operate. I think the wave of the future is that this is gonna be a thing, right? So in my introduction, she shared that I served as the CIE Task Force co-chair. Now I'm a HIT commissioner, and that work is going to evolve into that space. And I mean, nationally, it's being pushed down on systems to screen. And so at that point, it's like prime time is now to start to convene the necessary institutions, partners, or players in your space and get them around the table and talk through barriers, challenges, successes, opportunities, and kind of the vision and build it. It took us about 1.5 years, way back when we started with CHAP, to get to the place where we were ready to pilot. And that's because we brought the cross-sector stakeholders around the table and figured out what would work as a group. So when it came time to implement the thing, we were already all on the same page. And I think that's key.
Thank you so much.
If people want to send referrals to CHAP, we start with the relationship, and we start with an agreement. I don't initiate a new provider practice without doing what I'm doing with you, just more on an intimate level, making sure they know who we are, what we do, and also what we don't do. So they don't have, any off the wall expectations, essentially. So that's how it starts, typically with an email or a conversation and an interest. And then we work through what it would look like to implement the program or the referrals to CHAP from that provider's perspective. Good question.
I'm curious if you have any information about how the programs, like if there's any other income-based requirements or limitations within the programs. I noticed with I think it was the lead in the water one, there was a limit for household sizes, but I noticed it was much larger than most limits I've seen, which is fantastic. Do you know anything about like how those limits are set, or how many of your programs do or don't have limits?
You're talking about how many programs we refer to people that do not have eligibility? Well, there are many that have eligibility criteria, and it truly does vary on the source of funding, essentially. Most of the time, the people we serve are eligible for everything that we are sharing with them, but sometimes they're not. Like we have this bariatric relationship where we're receiving referrals for people who are undergoing or have gone through bariatric surgery. And most of them are commercially insured, so they don't qualify for the typical things. So we have to be creative. We actually purchase some things here that they would need. So when we run into a resources don't exist or client ineligible, we're trying to figure out, in my perspective, from my seat, how can I help with some of the funding that we have?
That's great that you have the ability to do that. Yeah. Excellent. Any other questions for Janée?
Well, you're gonna share my contact information after this, right?
Yeah, yes, I will. Are you okay if I CC you on the email?
Oh, not at all. I mean,
definitely.
yes, I am okay. Don't have a problem with that at
Okay,
all.
great. Wonderful. Yeah, if anyone else has any other questions that you think of, or if you share this with others and they have questions, you'll be able to follow up with Janée. Thank you so much. Yep, no other questions. Excellent. I will pull up my closing slides, and if anyone has any follow-up questions or comments, you're definitely welcome to send them in the chat or follow up over email afterwards. Thank you all so much for joining us today. Thank you again, Janée, for your fabulous presentation, for all the wonderful work you do at CHAP and the Greater Flint Health Coalition. We do have some upcoming events if those of you on the call are interested, or have anyone else who may be interested. We have 2 health and action work groups coming up in September. One will be focused on sepsis, one will be focused on mental health. And then we also have our next health equity work group is taking place October 3rd. The information on speakers and registration links will be available on the slide deck at Sendout. And that's really it for today. Appreciate everyone's participation. If you have any questions, you're always welcome to send them to us or to Janée directly. If you have any suggestions for future work groups or know anyone who would like to present, you're always welcome to do that as well. So on that note, that is it for today. I appreciate everyone's time. Janée, great. Best wishes and good luck at your next presentation. And thanks for your availability
you.
today.
Have a great one.
Bye, everyone.
Bye.